Hello class. So today we're going to cover silver diamine fluoride, and we're going to use this lovely, wonderful PowerPoint presentation by a good friend of mine, Alyssa Aberly, who does a silver diamine fluoride course for dental hygienists that are licensed and are not certified to place silver diamine fluoride in Colorado. And she's done an amazing job. So you'll notice that I know it's been a little while since we talked with the SDF rep from Elevate, and she did do a CE course for us. But this covers a little bit different elements. It's not focused on one particular product because you know that there are two types of silver diamine fluoride available in the United States. So, as far as studying and things go, you want to make sure that you can answer these course objectives and make sure that there is an understanding there. If you have questions or things like that, of course, always reach out to me through text or email, set up office hours, or phone call. So let's start with the history of silver nitrate. Silver fluoride, or AGF, was used in Japan for approximately 900 years. So you're going to learn here, silver diamine fluoride, the concept and the use of it are not new. These have been around for a tremendous amount of time. They were initially intended for cosmetic blackening, a little bit opposite of what people are trying to achieve cosmetically these days. And they had an unintended effect of caries prevention. And so they were using this initially for cosmetic purposes and then started to note those caries prevention qualities. Then we have silver nitrate. That is a caries arrest protocols were documented back in the 1800s. So again, silver diamine fluoride and its historical counterparts have been around for a very long time. In 1891, there was some official documentation where they had 87 of 142 treated lesions were arrested. And remember, whenever we use the term arrested, we can also interchange that for stopped, right? Those lesions become hardened. And so those are terms that we can use with our patients, right? We're going to arrest or stop the decay. So if we come back to the US in the early 1900s, we have GV Black, which, as you know through some of your other courses, way back probably in the beginning of dental hygiene school, G.V. Black is the father of modern dentistry. In 1908, Black documented protocols for silver nitrate. Right, so this was back in the U.S. in the early 1900s. In 1908, it was used to treat troops that were deployed in World War I. So one of the side effects to silver nitrate alone was that it makes the teeth brittle, right? So silver nitrate makes teeth brittle due to the loss of calcium. So that's not a desirable side effect of silver nitrate alone. And then in 1909, Black traveled to Colorado Springs to learn about the Colorado brown stain, which we've talked about that in community dental health, on some of the history and origins of just fluoride. So this later proved to be the result of fluoride, right? And it also led to a reduction in caries. So Percy Howe was the first research director at the Forsyth Institute in Boston, and the ADA president way back in 1928 to 1929. So we're encroaching on 100 years. Howe became well known for his successful treatment of caries with silver nitrate again, that other dental professionals began calling it Howe's solution. And it was advertised in the Journal of American Dental Association, I believe. Or it may be the Academy. Don't quote me on the official acronyms for JADA at this current moment. And then in the 1950s, we know that water fluoridation became the focus of prevention, right? We've talked about that in CDH. And then this resulted in a decrease in the interest of silver nitrate. So in the 50s, you can see how back in the 20s, the early 1900s, the 1800s, but especially in the US in the early 1900s, there was an interest, there was documentation, there was use of silver nitrate. But then once the 50s rolled around, water fluoridation was more of a focus and a push, and so the use of silver nitrate faded. And that's one of the reasons why it has just begun to make its appearance back in the US again. So now we have silver diamine fluoride. So remember, in the past, it was silver nitrate. And remember, what were one of the negative side effects to silver nitrate alone? That is a good something to take note of. So rewind if you need to do a little refresher on what silver nitrate alone, one of the negative side effects of it are. So now we have silver diamine fluoride. This was developed in Japan, and it was built upon that silver fluoride or AGF success, right? Silver fluoride, the AGF, is what was used in Japan. This added the remineralization properties of fluoride to the antimicrobial properties of silver, right? So whenever we did that silver diamine fluoride, the SDF, they also added NH3 plus to silver fluoride for stabilization. And remember, this is what was developed in Japan. And then Mizuho Nishino researched SDF for a PhD from 1965 to 1969. So think of that timetable, right? In the 1950s, the U.S. started focusing more on water fluoridation. But then in the 1965 to 1969, the late 60s in Japan, they were doing more research on silver diamine fluoride. So Nishino's research was published in the Journal of Osaka University Dental Society in 1969. And the SDF product by name was Sephorid, and this was released. And over 2 million bottles were sold. And they had 0 adverse outcomes documented. So remember that addition, right, of the fluoride helps reduce that brittleness that the silver nitrate alone can be a negative side effect of silver nitrate alone. But you add the fluoride and that reduces that brittleness. So if we come back now from Japan, back to the US, we come to much more recent years in the United States. In 2014, the FDA approved SDF for dental sensitivity. Then in 2015, Elevate Oral Care releases their Advantage Arrest, which that is who spoke with us about SDF initially. Then in 2016, Breakthrough Therapy was designated by the FDA. So this means we can use it for other means. And in 2018, SDI North America releases Revastar, right? So this is silver diamine fluoride plus potassium. There's also many notable publicity and popularity from 2016 and forward. There are new documentations of that also. In the Washington Post for Colorado, we're very proud that Jennifer Gieselhofer wrote about the silver diamine fluoride use, and she is a Colorado dental hygienist, so we always like to give her a little bit of a shout out, and that is a picture of her there on the lower right side. She owns a mobile dental hygiene practice, and Deserving Dental is a nonprofit that she also runs and owns. So what's the science behind the SDF, right? What's it made up of? These are important percentages to know. 25% silver, right? This is our antimicrobial. It's also important to know what these different solutions within the solution are used for. There's 8% ammonia, which is a solvent, and then 5% fluoride, which is used for remineralization. Now, we want to note, right, that the 5% fluoride is a higher percentage than what's in our fluoride varnishes, which is 2.5%, but it's less than half the volume compared to fluoride varnish. So overall, the fluoride exposure is less. Right, so it's a higher concentration, but there's more volume within the SDF compared to the fluoride varnish. And then the rest of the solution is made up of water. The Elevate Advantage Arrest also has a less than 1% blue dye, which whenever we start using that in clinic, you may notice that there's a blue tint. This is in place for Elevate's SDF because it helps the user be able to see it. Otherwise, it's a clear liquid. And then we also want to remember, so silver diamine fluoride itself, these are the components of it. The silver, the ammonia, and the fluoride. The Revastar also has potassium in it, but the potassium is not the main formulation of SDF that we focus on. So again, silver nitrate alone can make teeth brittle, but by adding fluoride, this helps strengthen the enamel and are optimal for those long-term outcomes. Another good point to remember are the benefits of silver diamine fluoride, right? We tend to focus on it for arresting caries whenever we use it in the clinic, but we can also use it to prevent caries, which can be a nice little added bonus if you place SDF, especially on occlusal surfaces on a tooth that has decay. Especially if they're molars, you can always do a quick little swipe while you're in that quadrant of some of those most posterior teeth to help prevent caries. Because we know if an individual has decay, they are at a higher risk for new decay. And then they also, for SDF, decreases dentinal sensitivity, which remember that is the original reason the SDF was FDA approved. However, we can use it for alternative use. And we use it for off-label use the most. That is its main use for dental hygienists and dentists. So how does it arrest decay, right? We have those silver ions that are bactericidal, right? So they kill bacteria, they prevent bacterial growth, and they deactivate proteins. Right, and so here's an example here when we look at this picture of how silver works. The silver ions break through the cell wall of that bacteria. They disrupt the respiration of the microbe, right? So they're disrupting that process. And then the silver ions attach to the DNA of the microbe to stop cell replication. So this is probably a very good slide section to know for your SDF exam. Now, what about prevention, right? So we talked about caries arresting. Now we know that it also prevents decay. So directly, it remineralizes dentin lesions. It increases lesion hardness, and it prevents demineralization. The SDF can penetrate dentin up to 150 microns. And here is a picture that is demonstrating that. And the SDF are is all the like pink in this image. So indirectly, and it can inhibit plaque bacteria in treated dentin resist biofilm formation. I have heard some slight rumors and think that there is definitely research coming in the use of Arrestin. Not Arrestin. I'm thinking ahead to another subject we're going to cover in treating using SDF in also treating periodontal disease, gingivitis, especially in those areas where we have patients that build a lot of biofilm and plaque. So also indirectly, we have the zombie effect, which is where the silver kills the bacteria. The silver killed bacteria kill active bacteria, right? So the bacteria that is killed by the silver then go on and kill other bacteria. And so they kind of help in the fight against bacteria that cause decay. So we have the direct and indirect ways of caries prevention. And it would be good to know these two, right? Direct remineralizes dentin lesions, increases lesion hardness, prevents demineralization. Indirectly, it inhibits plaque bacteria, and we have the zombie effect. So what about the efficacy for SDF? In caries arresting, there's approximately 90% arrest with 2 per year applications. So the most effective way to treat these decay lesions, carious lesions, if we're arresting them, is to be able to apply 2 applications. We have about a 40 to 80% arresting effect with a 1 application per year. Right, so that's important to remember, right? A lot of times we focus on the 1 application in the clinic, but especially since we've just begun using the SDF more readily, but we can begin to start applying 2 applications a year for that caries arresting effect to have the best outcome. When it comes to prevention, SDF prevents about 61% of caries lesions, which is a pretty good preventive statistic. It also inhibits the metabolic activity, that acid production of those S-mutans, more than sodium fluoride, right? And we know sodium fluoride is found in our fluoride varnishes, which is extremely helpful and beneficial. And we know that it is a good caries prevention for our patients. But SDF can definitely have a higher caries prevention status than sodium fluoride alone. So whenever we're considering this, we want to think of the caries risk of a patient, right? We're not going to apply SDF to every patient, but if we have a patient who is high risk or has current decay, then that SDF application on non-carious lesions can be helpful for those high-risk patients. There was also a meta-analysis that showed new caries decreased by 77% in children. And you can see these are the those references down here at the bottom. So what are some indications for use and the limitations? So indications is a nice long list. We have extreme caries risk, right? We just talked about that a few times. Behavior or medical management challenges for patients that have more challenges with their oral health, or maybe they have medication that increases their risk, which again, that can also fall under caries risk. More lesions than treatable at one visit. So we can treat areas of decay, and this can often be used in a long-term plan for a patient. So in practice, you'll see that sometimes, especially like, say you have a new patient, and you see them, you take x-rays, you do a comprehensive exam with the dentist, or you're doing a comprehensive periodontal exam, which we know includes hard tissue, but you are a licensed and direct access dental hygienist that doesn't work with a dentist on site, either exam works for this. You find multiple carious lesions, and you know that these need to be treated ultimately, right? They're too large to just use SDF on. But you know from your experience and just from looking, these lesions aren't going to be able to be treated in one visit, right? It's going to take multiple visits for this treatment to be completed. So we can place silver diamine fluoride, especially at that initial visit, and even at subsequent visits, to help arrest the decay, prevent future decay, and buy the patient time to get their treatment fully completed. And I have used that many times in my practice. I've used it as the primary type of treatment for decay, and also as a treatment that I can provide to help buy the patient time. And we do that a lot, right, with rifle offenders, because we know that it takes them a long time, months and months at best, to get into the facility dentist. And so we can do them a great deal of oral health care and supply them with the things that they need until they can be seen. SDF can be great for difficult to treat lesions, patients without access to care because it's very inexpensive, or maybe it's hard for them to get in to see a dentist, patients looking for minimally invasive treatment options. Maybe they prefer not to have like a drill and fill type of filling done, especially if it's a small lesion, or on a child or an older patient that may not be able to get into the dentist or just prefers not to have to go if they don't have to go. Reduce gingival inflammation and gingivitis. This is that one right there where I anticipate more and more studies. I very much think that as time goes on, you all will be using SDF to help treat gingival inflammation and gingivitis, because we know that it helps decrease that biofilm formation. Caries prevention, possible use as an indirect pulp cap. This is not advised in reports in over 80 years in Japan. So indirect pulp cap may be something that is being researched more. If you are in a practice setting similar to ours where you don't have a dentist on site all the time, this is definitely not something as just a dental hygienist that you're going to be using. And we can also use it to reduce aerosol generating procedures. Silver diamine fluoride can be placed without creating any aerosols aside from a patient breathing. And I have done it myself. And actually, sometimes I like it better than blowing air in the patient's mouth. Some contraindications and limitations. There can be possible concerns with a silver allergy, though some research says that it is not a concern because it contains silver ions, not silver like metal silver, for rings and earrings and things. And as dental hygienists, again, we do not want to use this if there is exposed pulp in the lesion, because this can cause sensitivity and a zinging feeling. And when you have worked with some of your instructors in clinic, this is one of the things, right, that some of us will help you assess. Is a decay too large that we are in a risky area where we could have some of that silver diamine fluoride absorb into the pulp area, causing sensitivity and sometimes pain for a patient, which is what we're trying to avoid. So some lesions, we will deem that SDF is not appropriate for them and that they really just need to get in and see a dentist to have more appropriate care provided. But that patient maybe has other lesions that could be treated with SDF first, and that way they can focus on the more deep invasive decay that needs full dental restorative care to even begin to care for it. Ooh. Make sure I didn't skip too many. So here's a little more on that SDF for gingival inflammation, right? Again, we don't traditionally use SDF for gingival inflammation, but you can see, and some of you may have seen this in some of your patients that have rampant decay, that they also have really inflamed gum tissue. But you can see the difference here. So these four are the same mouth here, right? Here and here, here and here, here and here, here and here. So these are four different mouths. And you can see some of that improvement, right? But we do have to be cautious, especially in anterior areas, that we know if decay is present, that can also lead to that black and really dark brown staining of the teeth. So we have to really make sure that we communicate that with our patients. But I anticipate that this is gonna be another level of use for SDF. So here are some differences in gingival index and plaque index between SDF and control groups. Remember those control groups? So the control group does not receive any SDF, and the SDF group does. And so we can see those differences. And we also know that a p-value that's under 0.05 means that it's significant, right? So these are significant. If we talk about CDH, this one is not a significant p-value. But of most of these, we have very good significance. And the closer we are to 0, the better. So we can see that those SDF groups had a lower plaque index compared to the control group. So another element that's related to within COVID-19, especially back whenever we were very focused on limiting aerosols, was the use of silver diamine fluoride. I haven't seen any studies currently, but I would not be surprised again with time that we will probably see an increase in the use of SDF, and COVID-19 and those new realizations and focuses on aerosols in the dental practice, which was just not something that we really paid attention to before, will really catapult the use of silver diamine fluoride. So similarly to things like we've talked about, telehealth use in oral healthcare settings, that we see some of those implementations and procedures and processes that were being used prior to COVID-19, but then throughout the pandemic has really catapulted us into using them even more. So I anticipate again that we'll see some data and information on maybe places that weren't even using SDF that routinely, they began using it more because they knew that it was an option. And SDF also is just getting more recognition in the public's eye too. And so you may find that you will start having patients ask you about SDF and if you apply it and use it in your practice setting, whatever that may be. Similar to sealants and things like that once the public is more aware of it, they're going to be asking for it and asking about it. We also can use SDF to optimize our schedules as dentists or dental hygienists. We can schedule more patients for less time. We can address treatment that has been left undone. We can also buy time for treatment plans to be completed, right? We touched on that earlier. Minimize those aerosols in the office. And then we can also use it in remote, community-based options in conjunction with interim therapeutic restorations also to keep patients from needing to come in the office as many times or for longer appointments. And we have watched the video of silver diamine fluoride application. The non-aerosol application is also a worthwhile watch that is in D2L. So safety, right? Because we will have patients that are going to ask us legitimate, important questions that are good for us to know. So when we talk to them about ingredients, there is less than 25% of silver ions present. There's no known medical risks for ingesting forms of silver. There can be the bluing of the skin. This is a good term to know, which is arguria. And so that is a potential side effect of silver. This is why we isolate and we dry, right? We make sure that we isolate the teeth before we apply it. And we want to make sure that we are being appropriate with our dosage. So the EPA recommends a lifetime exposure of 1 gram. The highest applied dose for 3 permanent teeth, right? So this would be 2.37 milligrams. So over a lifetime, you could approximately have 1,266 treatments to reach that lifetime maximum exposure. So a lot, more than a person would need. And again, that's the highest applied dose in research studies. So we are not necessarily applying 2.37 milligrams every time we see a patient. So in other words, getting the bluing of the skin from the use of silver would require much higher doses, like very, very high doses of silver diamine fluoride, which would be, I don't want to say impossible, but near impossible to reach in a lifetime. Toxicity-wise, there's a max dose of 1 drop per 10 kilograms or 22 pounds of body weight with weekly intervals. This takes into consideration that the lethal subcutaneous dose is 380 milligrams per kilogram and gives a 500-fold safety margin. So in other words, it's very safe. The possible or SDF side effects, possible small white mucosal lesions. If that silver diamine fluoride gets on the mucosa, this will disappear in 48 hours. It will stain lesions black, right? So this is why when we talk to our patients, we do not want to talk them out of silver diamine fluoride, especially if their decay is already black or dark brown in color. But most importantly, if we are talking about applying SDF in more cosmetic areas, such as the anterior teeth. In children, SDF will still often be applied on anterior teeth to avoid the need for sedation. And I have actually had my own experience with a niece who had some SDF applied on her anterior for front teeth. And she had more of a browning color because her decay was a bit more in the incipient stages. And then with time, it did fade. But her parents and their current oral health care provider had a really good conversation about SDF. And she was very young when she needed it. And so she would have needed to be sedated in order to fix and correct the incipient decay. And they did not want to have to sedate their child for that. And she was able to avoid restorations altogether. They were able to use SDF. And then when she got a little bit older and was more able to sit in the chair and be cooperative, they were able to place some anterior composite restorations over the dark spots. And then No research to show safety of SDF in pregnancy or breastfeeding. However, research is available to show that all of the ingredients that are found in SDF are safe during pregnancy and breastfeeding in low doses. So if we have patients that are pregnant and breastfeeding and they verbalize a concern there, we can reassure them that the silver, the fluoride, and the potassium are all safe during pregnancy and breastfeeding in low doses. So, our process. First, we want to get an informed consent, a separate informed consent, which is found in Dentrix. And this is not required. But since the products and procedures are new to most people, a consent is helpful for patients and parents to fully understand, right? So again, informed consent separate from your just general informed consent where we include SDF in your patient consent form is not required. However, in clinic, it is a requirement that we have that filled out. And it's an extra measure to ensure that treatment options are discussed and all covered, and the important points are covered. And it should include some color photos that patients or parents can not claim later that they were not aware of the staining or color change that would happen. We do not have color photos in our informed consent. I do not see a reason that we will be doing that, but we do have an informed consent that is required for patients to complete prior to having SDF placed. If you are placing it on an adult, you, the adult, and your clinic instructor can sign that informed consent. If you are doing silver diamine fluoride on a child, you can print the informed consent out and have the parent sign the paper form, and we can scan it into their chart. Here is a picture of the basic setup. Now, this is the Elevate, right? So you have, they have a setup here with the SDF. The extra brush is for the fluoride varnish that Elevate sells, which comes in a dropper bottle. When you use Revastar, you do need the two brushes, right? One brush for step 1, one brush for step 2. If you are doing multiple quadrants, you should have enough brushes for each quadrant. All right, so if you are doing one quadrant, you need one brush. If you're doing Revastar, you're going to need 2, a step 1 and a step 2. If you are doing 2 quadrants, you're going to need enough for 2 quadrants, 3, and 4, right? So on. So we're going to prepare our setup, right? We're going to make sure that we have a lined tray because SDF can stain our trays. We're going to have cotton rolls, gauze, dry angles, micro brush, our DAP and dish, 1 to 2 drops of SDF, fluoride varnish, super floss if needed, an air water syringe. If you are doing non-aerosol generating, you can forego the air water syringe because you won't need that. A basic kit with a mirror and explorer, gloves, mask, and patient bib. So that's what we want to make sure we have on our setup for our tray. We're going to isolate using cotton rolls, dry angle. You can also use a bite block if you need to, but we're going to make sure that we have enough cotton rolls and dry angles to properly isolate the lesions we are treating or the areas that we are using SDF for prevention. We're going to dry with the air water syringe. If you're doing non-aerosol generating, you're going to dry with gauze or with your cotton rolls. Then you're going to dip your microbrush in the SDF and you're going to apply a small amount for 60 seconds. You're not going to be removing any of the caries prior to application. You're just going to be placing the SDF solution. You're going to let the solution air dry for 60 seconds. Do not dry with air water syringe or solution will spread to other areas. And you do not light cure SDF, either form of SDF. Then you can apply fluoride varnish, which helps mask the taste of SDF and seals over the application site. In clinic, We usually will do a full fluoride varnish application once SDF is applied and you've finished with the patient. But you do want to let them know it does have a metallic-y taste, and that will dissipate quickly. But when it comes to SDF, it will stain everything it touches. Countertops, clothes, lips, cheeks, nose, gingiva, buccal mucosa. So we need to make sure that we isolate well and only apply to the lesions that we need it on. And we know in the oral cavity that it will only stain demineralized areas, but it will stain soft tissue. Soft tissue stains will dissipate. It takes about 48 hours. And we've already watched the little video before, but again, those are available in D2L to review, which I do recommend, especially before we return back to clinic. So here are some product comparisons. Revastar does not have to be refrigerated anymore, but as you all know, we've been trying to use up Revastar because we would like to just exclusively have Elevate in the clinic because it is a one step. We don't have the 2 steps like Revastar does. And it is generally less expensive. And you can see that difference there. Where a unit dose, which we do not have those in the clinic, but I have used them. They're little capsules that you open up, and they are great for mobile settings. They are $4.67, and you can treat multiple areas out of 1 unit. The $2.33 is per drop, and unit doses contain about 2 drops, right? So definitely more expensive for the unit doses. A bottle is $185, and it has about 250 drops, which comes out to 0.74 per drop. So 74 cents. So SDF is very definitely very cost effective, even at $9 a dose for Revastar, but that is considerably more expensive. So Revastar has the additional step of applying potassium iodine. You should remember that. Potassium iodine. And this can decrease staining. Long-term wise, not quite sure, but that is the intent of the potassium iodine. So make sure you remember that Revastar has potassium iodine in it. Elevate does not. And here are some before and after photos, right? So you can see those differences. And this is specifically with the Elevate brand. I have not seen Dr. McLean use other brands than the one-step Elevate. And here is the Revastar. And you can see how it's the Revastar with that potassium iodine, and it is supposed to decrease this darkness. But you can see in these pictures that there's not a big difference between the two, and it is an extra step. Which product do you think I like? Can you tell? So for follow-up, it's ideal to schedule patients in 2 to 4 weeks after that initial application. It's not necessary, but ideal. That way you can make sure the lesion is hard and dark black. If it's not, you can reapply. Restorations can also be placed at that visit if applicable. And remember that the best results for SDF is if it's applied at least twice per year for at least 2 years, unless a restoration is placed over the application site, which then you are not going to apply silver diamine fluoride to the lesion again because it will be covered. It can be a definitive treatment or part of a larger treatment, depending on the patient's needs and desires. These are 2 good points to remember for an easy true or false question. Additional treatment options is that it can be used to treat interproximal lesions with superfloss. They're not as successful as more like occlusal, buccal, or lingual lesions. And it can be used in combination with other restorations, such as glass ionomers. And it can be used for primary crowns or Hall crowns in young children. So these are some examples of SMART restorations. Right, so here's the application of the SDF, and then they've placed restorations at a later date. So here's an example of some silver diamine fluoride that was used for semi-incipient decay on some primary teeth. These are baby teeth. You can see the decay there, what it looks like in 2018, and then more than a year past, what it looks like. Again, here is that application and then afterwards. And remember, whenever we write referrals after we've placed SDF, we want to note the teeth specifically that we have placed SDF on so that patients, dentists, and other oral healthcare providers are aware that SDF has been placed there, because it can still have the appearance of decay, but does not have the texture of decay. So these are our procedure codes, which also are important to know for some exam questions. The D1354, this is for arresting, treating decay. The D1355 is for prevention of decay. And then if we use it as a desensitizing agent, we're going to use the D9910. And that's if we're using it for dentinal hypersensitivity or tooth sensitivity, right? And then these are the Colorado laws and rules regarding SDF. When you get into practice, some of this has actually changed very recently as of this, actually it's in here, effective September 1, 2021. So they rearranged in a Sunset Act specifically related to SDF where it was located in the Colorado Dental Practice Act. And so it is under now the prescriptive authority for dental hygienists. So you do not have to have such rigorous supervision as long as you have a prescriptive authority agreement with an acting DDS that's licensed in Colorado. You can place SDF where you see appropriate. And here are more Colorado laws and rules regarding SDF. And then resources. So if you have any questions, these slides are present in the D2L also. And we will be completing a test on these PowerPoint slides specifically.